You're listening to Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Silvio Inzucchi, professor of medicine, the Yale School of Medicine, where he serves as clinical chief of endocrinology and medical director of the Yale Diabetes Center at Yale New Haven Hospital, New Haven, Connecticut. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Welcome to Medscape in Discussion. I'm your host, Dr. Silvio Inzucchi from Yale School of Medicine. Today we're talking about cardiovascular effects of type 2 diabetes medications, and we'll get to that shortly. First, I'd like to introduce today's guest. He is Dr. Mikhail Kosiborod, a cardiologist and vice president of research at St. Luke's Health System in Kansas City, Missouri. There, he's also director of cardiometabolic research at the St. Luke's Mid-America Heart Institute, as well as professor of medicine at the University of Missouri, Kansas City. Mikhail is an international expert in the field of diabetes and cardiovascular disease, cardiometabolic, and cardiorenal syndromes. Welcome today, Mikhail.
Thanks so much, Silvio, for your kind introduction. It's a real pleasure to be with you as always.
Well, let's start with just a personal question before we get to the meat of a discussion today. What would you be if you were not a physician?
That's a great question, actually. My guess is that, I had a choice to make when I was a teenager because there were two things I was really passionate about. I grew up in a very medical family. So my dad's actually a physician, my mom's a dentist, my brother is a physician. And so medicine was always one of the things I was extremely interested in and was one of the top things for consideration. But the other one was music, actually. I played violin very seriously when I was a child. That went on all the way to my teenage years. And actually so happened that the city in which I grew up at the time in the former Soviet Union had a very high concentration of really talented violin teachers. And so some of the best violin players in the world ultimately came from that music school that I used to go to. So I was very much involved in music, classical music in particular, and violin.
Well, maybe at the end of the discussion, you can close us out with a little symphony. Mikhail, both you and I have been very interested in this notion of use of diabetes medications specifically for cardiovascular risk reduction. And we are clearly moving from an era of what we call glucocentricity in diabetes care. In other words, super focused just on the hemoglobin A1C, to a more, shall we say, a broader, more inclusive approach, which involves the close attention to cardiovascular risk reduction. Can you take us through the last few years in this area?
It's really been an unbelievable ride. So you may recall, and I know you make that point frequently, is that if you look at, I think it's 2015, circa 2015, international diabetes guidelines, it was all about hemoglobin A1C management. As important as glycemic control is not what the laboratory value looks like, right? I mean, typically patients don't come in to the office complaining that the A1C is too low or too high, or, that they have a problem with A1C. I mean, they know what it means. But at the end of the day, what really matters in clinical practice, what we really want to achieve and accomplish as a goal of management, is to make patients live longer and feel better. And the way you get there with diabetes, as any other chronic disease, is by reducing complication rates. And the two most common morbid complications of the disease are cardiovascular and kidney disease. So how do we make patients live longer and feel better? We reduce the risk of cardiovascular and kidney complications. And of course, in 2015, we didn't have the data yet, but now we do. And so seeing what happened just in the last 6 years and how the field has been completely transformed by these large-scale cardiovascular outcome trials, and how this kind of intersection of diabetes and cardiovascular disease, what we call cardiometabolic medicine today, went from being one of the least evidence-based fields in medicine to one of the best evidence-based, is just remarkable and incredibly rewarding, because many of us were hoping that that's exactly what's going to happen. But of course, back in 2015, we didn't know it was going to happen. So it's just, I think it's a remarkable chapter in history of medicine, to be honest.
Yeah, no, I fully agree. It's always been a bit of a conundrum that treating the most common metabolic abnormality of diabetes, obviously hyperglycemia, has had very little impact on the most common reason for morbidity and mortality in diabetes, which is cardiovascular disease.
I'm going to add to that just a little bit to say, look at kind of where things are going today, right? I mean, as a cardiologist, right, who's been interested in this for so long, I'm looking at the most promising developments for new medications for treating cardiovascular disease, both ASCVD and heart failure. And the most promising developments actually coming from this, kind of field of metabolism, if you will. I mean, not all of it, but lots of it is. These developments really have fostered, I think, a renaissance of this intermix between, first of all, seeing the whole patient, not just seeing a laboratory abnormality or an organ system, but thinking of, patient as a whole and the understanding that it's the same disease process affecting multiple organ systems, and also collaboration between different specialties, right? In the last 7-8 years, I've seen more endocrinologists and befriended more endocrinologists than probably I've had in the previous 35.
We're not bad folks, are we?
And it's not just endocrinologists, right? It's a nephrologist.
Right.
Yeah, we're now also, there is this growing area developing kind of between cardiometabolic field and oncology. I mean, there is just so much going on.
Yeah. Reminds me of the fable of the 5 blind men who are feeling a big elephant, and everyone is feeling a different aspect of the elephant. And that's what diabetes and cardiometabolic diseases has been, right? I'm focused on the glucose, you're focused on the heart, the nephrologist is focused on the kidney, but they're all the same patients. And, I think collaboration is terrific, but it's interesting that, as you pointed out, it's just in the last 6 years that we have solid data from large-scale clinical trials that have shown us the way in terms of which drugs to prefer in which individuals. So obviously we're talking about the 2 newer drug classes, the GLP-1 agonists, which are for the most part injectables, but there is an oral formulation available now, and the SGLT2 inhibitors. And they work very differently in terms of reducing glucose and also have a sort of unique thumbprint, if you will, on the types of cardiovascular events that they improve and also their impact on renal function. So the question for you now is, obviously, these drugs have pervasive benefits on cardiovascular risk. Are they used solely in patients with established cardiovascular disease? What about those of us who see patients who are at high cardiovascular risk but haven't had events yet?
Our good friend Darren McGuire and I had a debate at the American Diabetes Association back in 2020 on this very question. We know from cardiovascular outcome trials that patients that already have established disease clearly benefit from these 2 types of therapies, as you said, for different reasons, right? They work differently, they have different impact on a variety of outcomes, but they both have cardiovascular benefits, clearly in people who already have established disease. But what happens in people who haven't yet developed established cardiovascular disease? Should we be using it in that population as well? And of course, a very difficult question to definitively answer, because the lower the risk of the patient populations that you study, the lower is what we call in clinical trials event rates, right? So these are the rates at which patients are going to have things like myocardial infarction, stroke, hospitalizations for heart failure, cardiovascular death. And so studying that population becomes much more difficult because you need to enroll very large populations of patients and follow them for a very long period of time, which is not only very expensive, but also from a practical standpoint becomes very difficult in terms of trial mechanics, right? It's very difficult to keep people in clinical trials for a very, very long period of time. So how do you do that? Well, generally speaking, what we try to do is enroll some patients kind of in between those 2 groups, those that maybe have lots of risk factors but haven't yet been diagnosed with known disease. And it's been done with both classes of agents in a rewind trial with dulaglutide, which is a GLP-1 receptor agonist, that had a majority of patients that haven't yet been diagnosed with established vascular disease. And then in a DECLARE trial with dapagliflozin, which also included majority of patients that didn't have established cardiovascular disease with an SGLT2 inhibitor. So what did those trials show? They essentially showed that when it comes to prevention of heart failure, for example, for SGLT2 inhibitors, the effects are very much, in terms of relative risk reduction, almost precisely the same as what we see in people with established disease. And the same can be said about MACE, or major adverse cardiovascular event prevention, things like MI stroke, death from cardiovascular disease with dulaglutide in the rewind trial with GLP-1 arrays. So what does that mean? Generally speaking, if the drugs are really effective in working in the higher risk patient populations, they typically, in most cases, would also be similarly effective from a relative risk reduction standpoint in low risk populations, but it's just much more difficult to prove. At this point, I think given the data we have, it's pretty safe to say that they will work in a similarly effective fashion, even in low-risk populations, but the absolute benefits are going to be less because the absolute risk is less. And therefore, you need longer period of time to observe that benefit. But again, the horizon over which we're looking to get benefits may be much longer in those low-risk populations too. If you see somebody who is, let's say, a patient with diabetes at the age of 40 and doesn't have any known complications, the lifespan of that patient could be 30, 40 years. Versus you're seeing somebody who has had an MI, chances are that patient may not live as long. And so what you're really trying to do is try to prevent things in a much shorter period of time. And that's exactly why this agent's also going to be effective in doing that, because the absolute benefits are so much greater in that very high-risk patient population. So that's kind of my take on it. Of course, the one thing that ultimately becomes important in these decisions is not just medical or clinical effectiveness, but also cost. And from a cost-effectiveness standpoint, the lower the risk of the population, the less cost-effective the medications are, assuming that the medications themselves have a cost premium. Now, as they become generic, of course, the population of patients in whom it becomes cost-effective dramatically expands.
Yeah. As we've seen with the statins and the ACE inhibitors from 10 or 15 years ago. Same approach. Now, we spoke earlier about the different effects of these medications on cardiovascular risk, that there appears to be maybe more of an anti-atherosclerotic effect from the GLP-1 agonists. And what we're seeing with the SGLT2 inhibitors, particularly with the heart failure outcomes, which are quite striking, and also the renal benefits, which are certainly stronger than we see with the GLP-1s, that we're talking more of a hemodynamic effect. Can you tease those out for us?
Yeah, well, that's $1 million question of what the true mechanisms are. I mean, I think it's very safe to say that these two classes of medicines work differently. If you look at the main benefits of SGLT2 inhibitors, the most robust benefits, which I have to say, if you take a historic view on medications in cardiovascular disease, is quite impressive. And that has to do with heart failure prevention or treatment, as well as prevention or treatment of chronic kidney disease. And that, by the way, extends to people with or without diabetes. That's where, if you will, the SGLT2 inhibitors really shine. Now, there is some hemodynamic effect, meaning that we know these medications, SGLT2 inhibitors, cause at least a transient osmotic diuresis and a transient increase in a fractional excretion of sodium, even though that increase in the fractional excretion of sodium is quite modest and relatively short-lived. So it's possible that there is some contribution of that, but it's very, very clear, especially in heart failure trials that have been done, that you cannot explain all of the heart failure prevention or treatment benefit just by those effects. There is something else going on. And that something else may be actually much more important than the diuretic effect. Now, the key question is, what is that something else? Yeah, and, there are lots of different theories. There is definitely appears to be some positive remodeling effect on the myocardium, including positive effects on left ventricular hypertrophy, probably because of preload, afterload, possibly because of other factors. There are some metabolic effects that I think are really, really important. I know there was this ketone hypothesis that was offered by Eli Faranini and others, but it's unclear at this point whether it's actually the ketones themselves that have positive effect or whether it's things that lead to the greater production of ketones that do that. And there is enormous amount of research still ongoing to try to better understand that, but the story is definitely, it's not one mechanism. I think we can safely say that with SGLT2 inhibition.
What about GLP-1s?
Yeah, with GLP-1 arrays, that's another class of agents that really has complex, numerous effects. What we see with GLP-1 arrays is mostly kind of atherothrombotic events, things like myocardial function, stroke in particular, where the effects appear to be especially large, and as well as reductions in cardiovascular and total mortality that are a bit more modest, but definitely there and definitely significant. And so the question is, what mediates that? Of course, we know these medications lower hemoglobin A1C. We know they, especially with potent long-acting agents, they produce substantial amount of weight loss. And weight loss certainly could be an important contributor. We know that improving weight can improve lots of different cardiovascular risk factors. There is improvement in lipids and blood pressure that happens with these agents. The question is, what exactly is mediating that? Well, it's interesting because if you look at certain trials with GLP-1 receptor agonists like Harmony, which use dalbeglutide, an agent that has relatively mild effects on hemoglobin A1C and very little effect on weight, you see substantial improvements in MACE despite all of that. Mm-hmm. And what that tells you is that, once again, it's not just weight and blood pressure and hemoglobin A1C effects. It's got to be something else. And I think the best way I can describe current thinking is that something else may well be reducing inflammation, because these agents clearly have a relatively potent effect on at least broad markers of inflammation, such as high sensitivity CRP. And that may be one of the pathways. But again, I think the story is probably more complex than we typically make it to be.
I fully agree. Any insights so far on the possibility of an added benefit between these two classes, or even synergism? We talk about synergism in diabetes all the time, but do we have any data here?
Until recently, the data that we had was really on a kind of a surrogate markers of cardiovascular health, things like blood pressure and weight and hemoglobin A1C. And there were a couple of studies that looked at that with combination therapy. And what they really show is that there is a additive effect on weight, and there appears to be additive effect on some other surrogates. On hemoglobin A1C, it's a little bit less than an additive effect. On blood pressure, that does appear to be an additive effect. So there is definitely that type of data. And then the question really was all this time is, well, what about cardiovascular outcomes? For right now, there isn't a trial that has been completed that tested combination therapy versus one drug alone. What we do have, and probably the closest we get to it, is the Amplitude O trial, which was a trial of xanthine-based long-acting GLP-1 receptor agonists. That's the first GLP-1 array trial that had a reasonable proportion of patients on a background of SGLT2 inhibitors. Right. And they also stratified randomization by baseline SGLT2 inhibitor use, meaning that this was a kind of a key stratification factor. And what they observed essentially in that trial overall, epiglanitide reduced the risk of MACE. Interestingly, it also actually reduced the risk of heart failure as well as kidney endpoints. But what's important, I think is very interesting as well, is that MACE benefit, which we already know exists for GLP-1 arrays, was independent of whether patients were on SGLT2 inhibitors at baseline or not, suggesting indirectly that because the mechanisms of action are different and non-overlapping, that there is certainly very high likelihood that combination therapy may be better than either drug alone, even though once again, it's not a direct evidence of that hypothesis.
Right. I mean, it would be nice to have a trial, 3 arms, one with SGLT2, a second with GLP-1 RA, and then a combination trial. But it's going to be hard to power that study because all the drugs have beneficial effects on cardiovascular risk.
Yeah, and it's also going to become increasingly difficult assigning somebody to one drug or the other drug. Right. May become more and more problematic.
I agree. I totally agree. So in terms of the guidelines, we're now focused mainly on the American Diabetes Association guidelines in endocrinology. And still metformin is, for the most part, considered the foundation therapy. Although the most recent guidelines, there's some nuance there, suggesting that you might be able to go with one of these more evidence-based strategies first. But the first question that's asked as to drug number 2 would be, what is the comorbidity of that patient? So if it's a CVD, then either or GLP-1 or an SGLT2. If there's heart failure, an SGLT2. And if there is a CKD, not severe CKD, that the drugs may not be beneficial, but at least down to 30 or maybe even 25 for a GFR, then an SGLT2 inhibitor. Now, these drugs have gotten a lot of attention from both the cardiovascular and the nephrology communities. You just want to highlight what we know about these studies that have been conducted in both diabetic and non-diabetic individuals.
Yeah, no, I mean, I think once again, what we've seen over the past few years is now transition of these medicines, both SGLT2 inhibitors and GLP-1 arrays, from a diabetes sphere to being cardiovascular and kidney drugs. Right, so we have multiple trials with SGLT2 inhibitors showing heart failure benefits, both with reduced and preserved AF heart failure, regardless of diabetes, kidney benefits, regardless of diabetes. Now GLP-1 arrays are being studied for MACE prevention in non-diabetic individuals with obesity and established ACVD. And actually, we're doing trials now with GLP-1 arrays and obesity-related heart failure with preserved ejection fraction, regardless of diabetes. So I think we're in a brave new world now where we started with these medicines being thought of as diabetes medications. Then now cardiovascular and kidney drugs being studied, either already have established benefits or being studied for those. There is, of course, so much more. I mean, as you know, GLP-1 arrays are being evaluated in NASH and NAFLD. So there is a lot more going on in that regard. But these are no longer diabetes medicines, that's for sure.
I know I always tease you, Mikhail, about the fact that cardiologists are always stealing the endocrinologist drugs.
Well, they're not just diabetes medications, and I think we laugh about this, but drugs, of course, don't belong to certain specialties. They have multiple effects, numerous complex effects, and they belong to the patients, right? So we got to treat the whole patient.
Well, we're just about out of time. I do want to pick your brain about one last topic before I let you go. Screening for cardiovascular disease in asymptomatic patients with diabetes. What's the state of the art?
If there is one imaging test that, at least in my humble opinion, that one should consider in people with diabetes who are above a certain age, so I wouldn't do it on 30-year-olds, for example, but once you in an age where ASCVD is prevalent and you have diabetes, doing a coronary calcium score is probably not unreasonable. It's definitely has high discrimination power for identifying high-risk individuals, and may potentially impact clinical care in terms of preventative efforts. So I would say that probably be ones that I would highlight if you're asymptomatic. And nowadays, these tests are pretty inexpensive. So it can be done without a big financial burden on the patient. Symptomatic individuals, of course, is an entirely different story.
Very good. Well, thanks so much for sharing your insights today. Mikhail, thanks for joining us.
My pleasure. Always wonderful to be with you, Silvio.
So just some key points. It is a brave new world in diabetes management. We're more focused on comorbidities in our patients, particularly cardiovascular and kidney comorbidities, and selecting proper glucose-lowering medications in an effort to decrease event rates in our patients and not being as glucose-centric. Thanks for listening. I'm Dr. Silvio Inzucchi for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Silvio Inzucchi. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on type 2 diabetes.